All right, good morning, everybody. My name's Mary Jane Burke, and I'm very happy to welcome you here this morning. We're having an opportunity to begin to look at the guidelines in a more focused way. Dr. Willis won't be with us, but Dr. Santora, the Assistant Public Health Director, will be with us this morning. So we look forward to being able to answer any questions you might have around guidelines number 1 through 7. Just as a reminder, this will be recorded, will be available as of tomorrow approximately. Also that there's a availability for real-time translation in Spanish. So look forward to having our whole community join here. So Lisa, good morning.
Good morning, everyone.
Good. So we'll go ahead and start going through these slides. So welcome. Lisa Santora. If you could go to the next slide, please. I'll take this one, Lisa. This is just the background to remind everyone that a public health guided return to site-based classroom instruction was provided on June 18th. That came from both public health as well as the Marin County Office of Education. The guidelines have a purpose. They are guidelines, and they provide opportunities for members of our school community to use, I'll just say, describe them as guardrails, use those as guardrails as they provide their planning as we get ready to bring students back to school for the new school year. As a reminder, for those of you that are directly involved in developing your plans or wanting even more information about the guidelines, that after each of these calls, so we'll have this call, and then at noon today, there's also the availability to get some technical assistance from the Rethinking Schools team. So they will be available to you to answer any specific questions. So next slide, please. So guideline number 1 is essentially that provides a background that all activities are consistent with and will adjust to changing applicable state and local public health orders. And so Lisa, there's actually a question that I'd like to ask you here that is coming up a lot, and I am trying to get it in front of me real quick before we go through this. So here's the question. Given the daily news about California counties rescinding steps that they have taken to reopen, and that the governor has placed several more on a watch list, that San Quentin cases are surging, and that updates from national leaders were so dire this week, how can we possibly proceed with plans to fully reopen our schools for students and staff?
Great. I understand everyone's question on this front, because this is always going to be a very dynamic and fluid situation as we adapt to COVID-19 in our community. We are seeing increase in cases, and this is exactly what we expect to see as we increase social activity. And we are also managing our resources at the county level, making sure the impacts that we do see already happening from San Quentin as it's impacting our local hospitals, that our healthcare system remains ready to receive patients. And we remain reassured though by emerging data that shows that the risk of transmission in the child population is low, and also evidence that is showing the risk of child to adult transmission is low, as well as finally knowing that there are safety mechanisms that we can put into place to create a healthy and safe environment. It's not a no risk environment, but we can work together to lower the risk of COVID-19 transmission in our community. With that being said, we are not currently on the watch list at the state level. I would not be surprised if we do enter the watch list. That being said, it will not change much for Marin County. As we've mentioned on previous presentations, we have been one of the slowest counties in reopening. And the only fundamental change that would happen in Marin County if we are, if or when we're placed on a watch list, is the status of indoor restaurants. As we continue through the summer, we are going to continue to highly encourage outdoor activities and looking at those strategies as we move forward into the school year. We know being outdoors is the safest as long as we're not convening in large numbers outdoors. But this is our reality as COVID-19 establishes ourselves in this community, and balancing the risks of delaying further educational experiences for our children, as well as the risk of creating surge into our healthcare system. So we will continue to closely follow the data, closely following what's happening in our hospitals, seeing what's happening with the reopening of schools. I just saw today, I dropped off my kids for the last day of their first 3-week cohort. We did not close any of the school-based cohorts during the first 3 weeks with disease transmission, due to disease transmission. The highest risk that we're seeing in our community is not surprising. It's in family daycare environments, so in a home-like setting with younger children populations. And again, from a racial equity lens, it's also often individuals who are from communities of color, who are working very low-income jobs and live in crowded housing situations, who are often some of the child care providers in these settings. So I think that's what Dr. Willis and I will continue to look at as we move forward with the goal of reopening school for, I think, San Rafael, it's on the 18th, and working together with the districts as we provide this guidance to make sure they can implement the safety measures to protect the spread of disease in the school environment. That being said, things change constantly. As I mentioned, and just to put a point on it, we could see ourselves going into a watch list. Dr. Willis did mention that if we are concerned about a high level of disease transmission, we may need to issue new health orders, and we remain committed to having the systems track the data, being in communication with the schools to see the impact of the transmission of this disease in our community and to inform our decision making. But we need to be prepared for change as we constantly, that is our constant in COVID, is constant change, often at a pace that we're not ready for. And again, I think you've also heard Dr. Willis say August 18th may seem very close, but to us, it's very far away. We really work on a week-by-week basis in informing our decision-making and our policy changes and responding to emerging threats, for example, the San Quentin incident. So that's something that with all that being said, we want to be prepared and take this time over these next weeks to have our schools ready to open in August to launch school.
Mm-hmm. So Lisa, what we did decide is that before each of these calls, we would provide an opportunity for you to give a general update before we jumped into the area, each of these guidelines. Is there anything else in a general sense that you would want our community know now?
The first thing is, I think I'll mention San Quentin just because it's in our backyard. It's something we've been advocating as a county for a significant increase in leadership in the outbreak response in San Quentin. As you may have heard from us, we stand on the sidelines in this response. We do not have jurisdiction over San Quentin as a county county health officers. So we have been fortunate to have strong advocacy from our Board of Supervisors, our assembly members and state senators, as well as our congressmen, advocating at the highest level of the state that there needs to be stronger leadership to, unfortunately, at this point, mitigate something that was preventable. That's where Dr. Willis is today. They've have finally established an incident management team on the grounds of San Quentin, which was our recommendation from the beginning, from the get-go. And Dr. Willis is there to provide guidance on that front. We also are continuing to see increases in rates of disease in our community. And as I mentioned, that's to be expected. And we're moving into the 4th of July weekend, and it's a tremendous opportunity for us to not heed guidance. I know 4th of July for many is the time that neighbors come together, families come together in large groups, but that's the exact environment that we will see increased spread of COVID-19. So again, staying vigilant, really limiting social activity as we go into what is traditionally a very festive weekend for us, but really to consider your family situations and consider the risk of transmission as we move into this weekend.
So Lisa, here's a question. There's a lot of news stating that the risk with kids is that they can pass it on without even knowing they have it. Wouldn't that contribute to the community spread? information we've had is that kids don't pass it as much, but is it possible? We don't know because they don't get the symptoms when they pass it on. So the issues about kids and transmission.
Asymptomatic transmission is what makes this virus very successful in our community. But evidence, again, is showing that children, even when infected, are less likely to have a higher viral load to be able to transmit the disease. That being said, there will be transmission from children to adults. It's more likely to be the reverse, and that's what we've seen in the environments that we have identified children who have tested positive. It's generally the adult that is transmitting it to a child. But again, we see the likelihood of a child transmitting it to an adult as significantly lower than the reverse.
Mm-hmm. So this is a question about phasing in an approach to allow at-risk students with the greatest needs to return first, with students that have parents at home continuing to do the remote learning approach. Any comments about that? Or looking at elementary versus middle versus high school, as opposed to the opportunity for all ages to return to school.
And I think this is where we see this as guidance and guardrails for starting school, and really defer to the districts to make the decisions based on what is coming down from the state from a funding perspective, and guidance from the state as schools restart. And again, making decisions about phasing in or other strategies, leaving that up to the districts to really inform that. Our goal is to make sure that the schools and staff are ready and prepared to receive students. And some schools may be ahead in that. And I think, having engaged, this is an opportunity for people to stay engaged, to participate, as you guys are the choir, you're here at this meeting, and staying informed, to be participating in school site councils, or provide, staying engaged at the school level as well as the district level, to inform the best strategy for each school district. And again, I think from this is very much driven by an equity lens. There's variations across Marin. There are families that are unable to provide the supports at home for education that is needed. There's working families, two families that are two parents that are working that have been struggling. And we understand that some families have been successful with a pure home-based education, but we don't believe that represents our entire student population.
Mm-hmm. There's a couple of questions, and I've seen these before, that why when you're looking at information, you're looking at data from just Australia?
We don't look at just Australia. We look first at our data locally. I think that's where why I have a higher level of confidence is being close to the cohorts that we have opened, and understanding the nature of the experience of opening the pop-up childcares in our community. Then looking to data across the nation as well as internationally. The resources that we go to, we have a team of epidemiologists. We have epidemiologists at the state level that's constantly providing us with insights and information in the form of guidance. But Dr. Willis and I are nerds. I think it's still safe to say nerds. We're true nerds. We don't stop learning about COVID during the day. Our day is based on responding to COVID, and then our nights are going to the Lancet, Nature, our JAMA, it's another medical journals, and really PubMed is a great source if you really want to see it. PubMed on Google, they have all of the published information that's coming out around COVID. So it's gathering that data, looking at the meta-analyses of all of the studies that are being done to stay as up to date on the information around COVID transmission in our state, in our country, and internationally, to inform our decision making. That was just a simple study that demonstrated a point, but we look at many studies.
Mm-hmm. So what if there's a surge in COVID cases in August? Will the guidelines change, number one? Or to put it a little differently, what could happen that would essentially have Dr. Willis, as well as you, Lisa, make a shift in the guidelines related to school opening?
I don't, how our landscape is changing, we're really seeing the surge the surge that is ahead of us right now has some is directly related to San Quentin, which is an older population of inmates who have been transported out of San Quentin and into our healthcare system. The other surges that we're seeing are in our nursing home settings, where it's older adult populations that, because it's another congregate living setting, that they are at higher risk and they have other vulnerabilities. So just because cases increase and there is a surge does not mean that it would affect the start or closing of schools. I think we're going to be looking very specifically at both population level data, specifically looking at if and when, I'm not even going to say when we do have the first positives in some of the cohorts, how is the disease moving through a school? If it necessitates, again, I think some people may remember in the spring before we closed schools, there was a decision that the school closes. And so I think that would be what we would be following is, are we able to truly contain COVID-19 transmission into a singular cohort and closing the cohort? And that's what we've been able to do already throughout the summer, is maintain operations of childcare and camps, and only needing to close one COVID affected cohort. And again, these are aggressive mitigation strategies. That's us, again, going above and beyond. It's not what we do during flus in response to flu or norovirus or other things. And the reason why we're being so aggressive is because we still, again, are buying time for ourselves to learn how this virus acts in our community.
So Lisa, who has the final say? CDE, the State of California Public Health, the CDC, the American Pediatric Association, or Marin County Public Health?
Many people can have a say. There always can be federal orders, which we haven't seen federal orders come into play. What we have seen are state orders. So the state is the ultimate, the governor can order closures. You've seen that in some counties that have been placed on a watch list. Then local jurisdictions like Marin County at our jurisdiction has the next level of authority, and we can be more strict. We can't be less strict than the state order, but we can be more strict. And that's what you've been seeing right now, is that our current closures are more strict than the state order. And then even local jurisdictions, and this has not been what we've seen. We work closely with local jurisdictions, but even local jurisdictions can be more strict than the county. So it really is, the authority is in the government. There is money that's involved. And so there are state senators, et cetera, that also can make decisions at the assembly and state senate level around how things are funded. That could also influence changes, but that's definitely not my area of expertise.
Okay, so we're going to move on to guideline number 2. So this guideline, health and safety practices and protocols are in place, including hand washing, appropriate face coverings, access to essential protective equipment. So Lisa, this issue about masks continues, or excuse me, face coverings continues to be a challenging. In fact, in today's chat, many questions about the face coverings, the age of the students required to wear the face coverings. Is it reasonable for a student who is of kindergarten age to have to wear a face covering? You yourself have talked about the issues about students and their misuse of face coverings, i.e., using them as slingshots, et cetera, et cetera. So we've got that issue. I know that our original guidance was grade 3. The local guidance, would have been grade 3 to grade, from then on, that we'd be wearing face coverings, but then the state came out with a more restrictive face covering order. So could you just talk about that again? Why is this needed?
So before I go there, I want to say that the other jurisdiction is the school district. And just remind everyone that sometimes we provide guidance and the school district itself can be more strict than guidance that's provided by the health officer, because your school district also has elected an elected board. And so that's the other level of authority. So I just wanted to mention that. The face coverings is a challenging issue. We, as a Bay Area, all uniformly agreed that over age 12 at first was where we saw the best implementation of face coverings. Face coverings are effective as a tool for reducing the transmission of COVID-19. Then And then then when we did release this guidance, it was, as Mary Jane mentioned, it was dropped to a younger age. And now again, it's guidance. I've seen it written as an order from the governor, but it is guidance from California Department of Public Health, strongly recommended by the governor, but it's not an order around face covering. And so throughout the summer, we've been maintaining language that each facility really needs to determine what is feasible and practical in that cohort, and that in the cohort that they're working with, or the student group that they're working with. And so we did not order an extension of the face covering order for this summer to parallel what the guidance from the state. And it will be a challenging area. I think it'll be something that we continue to have conversation as schools actually start, and as teachers are managing children in the classroom, depending on their age, to hear back from the schools of what is practical and feasible and doable for children. I have seen children, when supervised, wear masks we see it as we go out into the community. I also know the challenges as a mother of reinforcing mask face covering use among children. So, and I think this is where we are launching our guidance with guardrails as strict, again, as possible, but I think we want to demonstrate the adaptability that this may be an area of change as we move into the school year, and hear that there may be, you think there might be more benefit than harm. But again, if it becomes a challenge, we'll be listening to feedback from the school staff around face coverings.
Mm-hmm. What is if you'll just talk a little bit about face shields.
So face shields has come up a lot, especially with the ability for teachers to, for learning, to be able to see the mouth of a teacher when they're talking and not to have those barriers. The downside of the face shield itself is that it doesn't provide full coverage if there's a sneeze or a cough. It's not yet recommended as a way, as a general recommendation that an instructor wear a face shield while the students are wearing their face coverings. I could see it be feasible, and again, this is where I think we're going to be learning together. I could see it be feasible if an instructor is maintaining more than 6 feet of distance and they want to be able to present to the classroom wearing the face shield. And I think this is the gray spaces that we'll navigate together. It's just not recommended, but if a teacher is maintaining 6 feet, it probably provides good practice. There are some face shields that have a further down to prevent that kind of spread if they're sneezing and coughing when someone is talking. We're not recommending that at this time. The other emerging innovation is actually clear face shields. The first iteration I've seen, the US version of it, is a little janky, substandard. But there's new clear face shields that are developing in Europe that I think also might be useful for teachers or speech therapists, people that really, and again, just to ensure children who may be hearing impaired to be able to see lips, to make sure we have accessible education for all. So it's not a recommendation. It's something we'll look at probably on a school by school basis, or even a staff by staff basis. And it might be something that changes as we move forward. Again, we've all adjusted to being not together and feeling safe when we're not together, and we'll all are going to learn how to start convening together in a classroom. And again, what modifications are optimal and beneficial, and what modifications that have been recommended in our guidance that are not practical and need to be modified or adapted to create a healthy learning environment for all.
So just for everyone on the call to know that the questions that are here showing on the screen are a result from looking at other questions that we've received previously. So there's the next three talking about what if there isn't a sink in my classroom for hand washing? Who will be supplying the EPE? Will there be enough? What kind of EPE is required? There have been trainings around each of those issues that are available online at the Rethinking Schools website, but just go to, if there's not a sink in my classroom. Lisa, could you address the issue of hand sanitizer versus what if I don't have hot water, by way of example?
Right. So soap and water is always best. Again, I think even if we were to honestly poll people though, most people aren't washing their hands like they're supposed to the full 20 seconds and in the right, with the right friction and the right procedure to ensure effective hand hygiene, which is why we do recommend the hand gel. Of course, there may be scenarios with a student encounter that you really do need to wash your hands after, again, let's say a norovirus event in a classroom. And of course, we want to make sure that that it's available for staff to have access to a sink. But generally in the classroom, the hand gel and hand sanitizer would be sufficient to meet the hygiene needs. And again, really just maintaining, also just having a different awareness. I think we're all moving differently. We're not as close and we're not having as much physical contact as we used to. And that's your first, your first buffer is maintaining some of that physical distancing.
Great. So Mike Grant, I know you're here. Could you please describe who's supplying the EPE? Will there be enough and what kind of EPE is required? And then I'll ask Lisa to weigh in if she has anything to add.
Yeah, so the state of California, can you hear me, Mary Jane?
Yep.
Yeah, so the state of California Office of Emergency Services is in the process. We just shipping out PPE throughout the state through the county offices of education. We just received pallets of PPE, EPE that the Santa Fe warehouse has received. We'll be breaking it down proportionally per.
Wow, he froze.
So Mike,
hey Mike, sorry, you froze. You're freezing up just a little bit, so not sure if it could be. Can you go back to? We just received a pallet of PPE, EPE from the State Department.
I'm sorry, Mary Jane, you cut out for a second.
Okay, so we're just trying. We lost you on the fact that the state is sending PPE, EPE through county offices across the state, and Marin County has just received.
Yeah, so we received 15 pallets. We'll be breaking it down by district and distributing it next week, Monday and Tuesday, and there'll be a second wave of supplies that will be received for private, independent, and parochial schools. We're waiting for the timeline on that as well. And it's essentially hand sanitizers, disposable face coverings, cloth face coverings, size for both students and for teachers, thermometers as well. But those are the basics, and hand sanitizer.
Okay, great. Lisa, anything to add before we move on?
No, I just saw a comment about the just some fear and anxiety about having gray space as we navigate. And again, our goal always in public health is to provide the tools people need to have a safe environment. With that being said, there's always risk as we enter into any environment. This group is more keenly aware of that, especially during flu season and norovirus and other infectious diseases. And again, which is why we, while there may be space again as we are going to become adjusted to wearing face coverings, there will be a time in the future that face covering will not be part of a regular school environment, and where some of the changes in some of the isolation and quarantine recommendations that we have right now may be reduced sooner than we expect in the future as we learn more about this disease, and where this school year, where we check cohorts because there's a positive case in a classroom. That's not what we do with flu. And it's going to take time for us to evolve together. And I appreciate everyone's trying to make the best decision on risk. And again, I think it's just for us to work together. As Dr. Willis said on our last presentation, we cannot create a no risk environment. None of us live in a no risk environment. It's really trying to optimize the benefits of our having classroom-based education and minimizing where we can risk as much as possible. And that's what we remain committed to.
Okay, great. And any additional EPE you think is necessary?
No, again, I think these are just really finding our locus of control in those basics. Where it is hand hygiene, it is maintaining physical distance, knowing in some classroom settings, physical distance is hard. it is, changing clothes before you return home and re-engage back with your family if you're concerned. There's a lot we can control to minimize the spread of a virus in a school environment. So just building confidence, and some of it's practicing. It's practicing washing your hands. It's practicing putting on and taking off a face covering, and recommending everyone just take the time to watch those videos and to read that material, because there's much that we can always improve upon. Again, I am the worst culprit of not washing. I know how to wash my hands. I've been actually trained to wash my hands very well, and I know I fail in demonstrating competency at that sometimes. So.
Great. Okay, thank you. All right, guideline number 3 is trainings provided to staff, students, reinforcing the importance of health and safety practices and protocols. Mike, I'm going to have you take that, and if you could just quickly highlight the trainings that are available.
Yeah, so we've conducted numerous trainings that are online on the Marin County Office of Education website under Rethinking Schools, and it includes, how to set up health and safety stations, how, the difference between cleaning, disinfecting, and sanitizing. There are certifications for a school staff to use a disinfectant. There is a required training, and the Keenan Safe Schools they just created a new kind of condensed training specific to the use of disinfectant. How often should I be cleaning? It's frequently, as often as possible, particularly high touch areas. And then disinfecting is done at least once a day in those areas, including restrooms and sinks and high touch areas.
Okay, great. There's another one. Yeah, Lisa, anything else on that?
That's just, again, there are studies where we're seeing when there are cases transmitted in the work site, it's because people aren't cleaning those frequently touched shared surfaces. So it was a study done in a healthcare system, and it was because of a mouse that was used by multiple people. So right next to me, this is not planned, I have I'm in an office by myself. I have my Santa Claus right next to me. I wipe down my phone, I wipe down my computer, I wipe down a phone that might be used by someone else, because you don't know. Most times the classroom gets left, but you don't know. I wipe down my surfaces. So it's basics that some training is important to have, but there's just also common sense applications, and again, reminding ourselves and staying vigilant that you do wipe down surfaces, especially shared surfaces, and doing it as much as possible. Some days I don't remember to wipe down the surface. Most days I do, but again, just trying to create a practice. Yep, and I have my hand gel, which I'm almost due for another one. And that's just creating those environments. And then with face coverings, I'm not wearing a face covering now. It really is, it's recommended at this point, if you're just indoors, wearing that face covering, especially if you can't, and you have to wear a face covering if you're indoors and you can't maintain a 6 feet distance from someone right now. So that is the recommendation, is wearing it when you're indoors. People do need a break. I go on campus with my kids. I don't wear my face mask as I'm on the campus. It's outside. As I approach the door to drop off my kids, I put on the face mask, and I see the staff wearing their face mask, their face covering on the inside. So it's something. That being said, the more you manipulate your face mask, the more likely you're likely to touch dirty parts of your face mask, especially if you don't know the front and the back.
Lisa, this is a question that'll come later, but now several people have asked it. Will there be testing required for school employees when they return to school?
It is not required at this time. We're having conversations this week and into next week about what recommendation we would make specifically for school staff. The challenge, so one, potentially what we've seen in nursing homes is establishing a baseline test. That being said, there's significant restrictions or limitations to a baseline test, because you may be test negative at baseline, and then your activities that follow will increase your likelihood to test positive in the future. But that is something we're considering, is recommending a baseline testing for staff. That is a surge in our system. Anytime we recommend staffing the school staff, and educators are a large bunch. So we are working internally with healthcare partners to make sure we also have the resources to back up that recommendation. So we don't have a recommendation at this time. It's something that may be forthcoming, and we're looking at a baseline testing. At this point, we're not looking at serial testing. It's a heavy lift on our system, and we're not seeing a lot of reliability when you test asymptomatic people who have not had close contact. The most reliable test is when you have symptoms of COVID-19, or when you have a known close contact with someone who has COVID-19, and you test at the right time after your last exposure. Otherwise, there's a higher risk of false negatives in testing. And that's why generally, just to remind everyone, we're still in an emergency response. So the tests that are available are for emergency use only. They're not like our other surveillance tests. For example, some of our cancer screening tests, where there's a significant amount of research that demonstrates the costs and benefits of recommending a screening. So that's why the FDA, the Food and Drug Administration, has issued significant caution in the use of the tests that are available for screening, because there's significant limitations as a screening tool.
Okay, sorry, as we move on, Mike, can you address the issue of school bathrooms? How often are they going to be cleaned? Are going to be cleaned between cohorts, etc.?
Yeah, so this is obviously an important one and a challenge. On our website, under the cleaning and disinfecting training, there's a pretty thorough document that has the frequency of cleaning for all the different types of areas. Restrooms are as frequently as possible. It needs to be disinfected at least once a day. There's been questions about, should it be cleaned after each use? And the answer is no, that's just not practicable. However, it is important to train students and staff. When you walk into a restroom, there are practices that you can develop that minimize the amount of things that you touch. And there's also, best practices of no touch soap dispensers and no touch faucets, and those things. If you don't have them, there's a time and expensive in involving that. But our sense is that there will be at least a midday cleaning by a custodian or staff member, and to teach practices where students and staff are being as clean as possible.
Okay, we're going to move on, please. But Lisa, just for you to know, one of our chats is saying that Dr. Willis gave a different answer than Mike just gave. So Mike, will always go with whatever Dr. Willis said, right?
I'll go with Dr. Willis, yeah.
No matter.
No, I think it was about
sorry.
testing.
Oh, it was about testing. Oh, sorry.
Okay. And I think, again, that's where there's harms and benefits of any public health recommendation. And we are learning together as we start schools, as we have different experiences with testing as a baseline screening, for example, like I described with the nursing home. And again, we have not issued a recommendation, and this is where we're trying to be as transparent in our decision-making process, where what our steps before we make a recommendation is to consult with the other health officers of the Bay Area, to consult with the state, to look at practices that are emerging. California isn't the only state that is that's rethinking schools and looking at practices from other states. And then when we issue the guidance, that's when we have affirmed our recommendation. But as we engage with you now, I'm just sharing with some of the considerations that we have. Again, trying to sometimes, for example, this might come up. I'm going to jump ahead maybe, but for example, temperature checks. It's another great example. Temperature checks and baseline screening fall into two buckets for me as a scientist. They're not very reliable. They're not. They may misinform because they may have false negatives. But then they also, that being said, they also may heighten vigilance. So, for example, if a parent knows that there's going to be temperature screening upon arrival, they may reconsider sending that child to school if they're starting to develop symptoms or if they have any concern. So there's a benefit of that screening process. But again, that might be something that, even though we have guidance now, may evolve, where we could hear, and this is, I think this is very possible situation to develop, is that the practicality of screening students, the number of students that have to enter a school, and the benefit, and weighing that against the benefits of that type of temperature-based screening, we might identify that it's not practical. And that, again, that's not what's in the guidance now. And I think that's where we're just hoping to show you that we're in conversation, trying to study best practices, hear what's the realities of instructing in the environment that you're going to be instructing in, and adapting to reality, adapting science and reality. So that's
so Lisa, guideline 8 is up for next Thursday, and it's all about testing. So, and
get ready.
So get ready. And the other part that we're working on is just trying to figure out, you know, how is it that we would provide opportunity for 5,000 educators, and that would include public, private, independent schools, you know, to get that. And just for everyone to know, we're also working with Kaiser Permanente on that. Okay, guideline 4, that there'll be a single point of contact identified at each school, so that if there's a question that comes up at a school, there's somebody that the school staff would be able to go to, and that person would serve as the liaison to public health. And so let's start with, what's the role of that liaison, Lisa?
So for us, this is a critical role. This person who's identified, and I've mentioned it before, someone that loves spreadsheets and is very organized. As we move into the school year, we know we're going to be behaving differently if there's a COVID positive. And that means, at least as school year starts, we'll be closing cohorts and then making recommendations based on identifying the infectious period of a person who tests positive, confirming who was exposed and when they were exposed, and then making recommendations for testing of possible exposed individuals, and making recommendations for the closure of a cohort and the reopening of that. So that we are successful when we have a solid point person on one side. It could be a nursing home or a school, and a solid point of contact on our public health side, so we can work together to understand some of the nuances. As you guys know, no day is the same in any environment, and not all people are exposed, and there's always nuance to finding out. The game of telephone of that tracking down if it's really a true case, tracking down the results just requires to have a really solid point of contact between both the school itself and public health. Okay. And then we are here for support first. A lot of times, most of the calls that I get are people are from workplaces that people have already re-entered the work site, and they think there's been exposure, and they want to send everyone home. And what I'm seeing is that most of them are not true exposures. We're doing a better job of communicating to people that they may have had an exposure. That does not mean that they have COVID-19. But as much as people are educated, we still see confusion about the difference of being exposed, the difference around being a close contact who's at higher risk for contracting COVID-19, and for being a truly positive COVID-19 person. So a lot of our phone calls are just navigating and reassuring that the school is making the best decision around staying open, and how to notify the parents, and working together to make sure everyone is aware about what our recommendations are, and understand why we may not be closing a cohort, why we may be closing a cohort, and why the cohort may be closed for so long, even though the kids seem healthy. And so that's why it's so important for that. We're working on developing trainings now. We don't have the benefit that every school has a nurse in our schools, and so we recognize that our point of contacts often are not nurses. They're amazing administrators and staff. I go to a school that Ms. A, shout out to you. She's awesome and very organized, and works with her team there to make sure that they're in contact with public health along with the school nurses at the district level. And it's a partnership. And so we'll be developing, we've already increased the number of nurses on our side to prepare training and to be more available to schools as we go online in the fall.
Okay. All right, I think we can move on then to the next guideline. And this gets more into cleaning, but so Mike, I want you to help us. Plans implemented for intensified cleaning. And so essentially it identifies that you actually have to have a plan, and this would need to be in every, school's site plan. We talked about the bathroom what's the difference between cleaning, sanitizing, and disinfecting? I know that's covered in the training, but could you say a few words about that, Mike?
Yeah, so cleaning is essentially, you know, soap and water. Ideally you clean before you sanitize and or disinfect. Sanitizing, you know, takes away, you know, 99% of the bad stuff. Disinfecting takes away 99.9%. And disinfecting is the one that takes additional training, and should be done, you know, primarily by custodial staff at least once a day, sometimes more if possible. Sanitizing is work in our setting here at the county office. In our school setting, teachers and secretaries and all staff have been trained in sanitizing. So that's just spraying and wiping. It's less strong, but it's very effective. Okay, so that, and there is a great little short video on our website that goes over that as well.
Okay. So Lisa, this is for you. When teachers are cleaning, so let's ignore teachers, but just say staff or teachers, whoever, will that put them at more risk for getting sick?
It should not, as long as you're following regular procedures. The risk of you getting sick is if you touch a dirty surface and then you, with that unclean hand, wipe your nose or your mouth and inject virus into your system. So if you're using I don't use gloves when I showed you my lovely sanitizer. If you use your sanitizer, wipe down the surface, that generally should be fine. You then can go the extra step and then just hand gel yourself after sanitizing the surface, which sometimes I do, sometimes I don't. The real key is not touching your face and not touching your nose and injecting virus into your system. So I do not believe that sanitizing, following basic instructions, would put anyone at additional risk.
Okay, sorry. When do we need to use gloves?
So I've heard Lisa say, you know, she's not a big believer in gloves. It's more important to wash your hands, because when your glove touches an infected surface, it's just like your hand. But we have gloves available, certainly for sanitizing and disinfecting. We make them available. We feel like it's an important extra layer of protection, but it's also using them appropriately and taking them off appropriately. But we have gloves available at all of our health and safety stations at our schools and our county office of education.
And that's something I commonly see. It's not the most common thing I see, but I definitely see people in the community wearing gloves. And then I see them wipe their face with their gloved hand. So it does not offer that protection. I wear gloves when I'm doing medical procedures. When I'm out in the community, I don't wear gloves generally. In my home, maybe if I'm doing some deep cleaning. But again, I think our concern always is that as you add some layers of protection, you skip on some of the basics, like Mike said, around hand washing. And again, just remembering to keep your hands lotioned. If you're hand washing the right amount, then you should have very dry hands and need hand lotion. That's when you know you've washed your hands enough.
Mm-hmm. So Lisa, you mentioned the issue of closing cohorts. So there's a question that says, how is it possible that you would be able to close a cohort to at a high school of over 2,000 students?
This will be one of our more challenging cohorts to close and to identify the true cohort and to close, and it will have the largest impact. That's why we are committed to listening to districts on how to most ideally cohort students that have very varied schedules. And we do that. That's what we're trained to do in public health, is identify where one person who is positive and where they may have traveled into different classrooms. And we know that the classroom, the high school environment and the middle school environment will be more challenging just because of the larger size of the cohorts and tracking that. And we're on a great call with students who are developing an app for helping us and tracking. And so we'll see if that is something that a student developed app may help us at the high school level. And it's going to be a challenge. We're going to try, we're going to have very rapid, we call it rapid plan, do, study, act cycles, especially at the launch of the schools. And our first high school and first middle school cohort closure absolutely will be a learning environment for all of us. And I think that's why we're committed here over these next weeks to getting our basics drilled down on attendance and rosters, working with the districts to see if there's any way to truly cohort. And then what we heard from the students is that they might be cohorted, but if they're not with their friends, they're going to still hang out with some other groups. And so having a way where they're not punished for reporting that they have hung out with different cohorts. It will be a challenge, and it might inform our decision making around, again, the feasibility of that strategy, especially if we see poor outcomes. And that's what's going to drive a lot of our decisions if we see aggressive transmission or poor outcomes in this environment. We'll be closely in touch with the schools and the school districts to inform any changes in our recommendations. And it's hard. We're going to learn together on this as we reopen.
Okay, next, let's go to number 6. So this, you've touched on some of this, but the topic about what would the health screenings look like for students and staff. The guideline is they'll be conducted daily. There have been some trainings on this as well, but this will just take us to, in our pilots, we have been using temperatures. I mean, as you know, we've been actually taking temperatures. And Lisa, do you want to say any more about that? About the temperature taking? I think that's going to evolve a bit, right?
Yeah, I anticipate this evolving. I don't know when. I think right now, again, it's working, but I don't know how accurate the information on the temperature screens are. And again, someone can be asymptomatic without a temperature and still have COVID. That's the reality of this disease.
Right.
So,
and just, yeah, sorry. In all of the pilots, there has not been a single student with a temperature above the 100.4. The one time we did find that, it was a faulty thermometer, as you know, but we did close the cohort. But anyway, we're going to need to see that. It does seem, though, that people feel more comfortable. Do you know what I mean? Just knowing that we're doing that. So I think that'll be something that we can think about.
Yeah, and I think that's where we'll be weighing the benefits and risks. If a parent knows that their child's going to be screened for a temperature, I know plenty, not me, because I'm the deputy health officer, I'd never do this, but I know parents that have sent students to school, and I know probably more staff report to work when they might have a low-grade fever or feel like something's brewing. And I think this is where, back to the basics, as much as we can educate first families and staff to stay home when they're starting to feel sick at the start of that sore throat. That's not the time to go to school. So that's our first education. 2, just really reminding people as we go into the school year to minimize social activity outside of the school environment as much as possible. We're striving to create, to balance the risks and benefits, knowing that there's activities and educational activities that are important for the well-being, but there's other ancillary activities that we may need to reconsider, because again, the more that we're socially interacting, the likelihood of transmission increases. And again, always to be aware, we're going into a fall season where there will be other viruses and other infections that are transmitting. And there will be a lot of false alarms for COVID, where children will be sent home, they'll test negative for COVID, and then they'll be coming back, and because they might have something else. And so I think this is just going to be, I think this will be one of the areas that we follow very closely at the launch of schools, again, to see when it's implemented and on a much wider basis around temperature screening. Is it an effective tool for us? And this might be a place, again, where more research comes out that's not directly from just the firsthand experience that we're having here in Marin County, but from either CDC or other states to inform our decision making.
Mm-hmm. So the next question is about what's going to happen before entering a school bus. Just for everybody to know, the guidelines around transportation, school buses, etc., are actually being worked on right now by a broad-based committee. And there's definitely some thinking that in order to be sure that before a student even begins their way to school, i.e. get on a bus, that we will be considering health screening. So we're talking about that right now. It's in the preliminary draft. The next question has to do with student shows up, they have symptoms, what's the plan, where are they going to go? And so just for people to know, the plan that is outlined is that, in fact, a student, if there is a student or staff who has symptoms, they need to be immediately masked, which they will already be, but isolated. Obviously the staff person would be going home. The student would need to be picked up by his parent, his or her parent, and we know that sometimes that's quite a challenge that educators are framing, that the parent is busy, whatever the issue is, they're not unable to answer the phone, very, very busy, or maybe even unwilling, right? And we're really going to have to work on that in a very, I think, significant way. And we've talked about a variety of things, like we need more than, just the parent's name and number and the number 2 person we would call in the event of a situation, but maybe we need additional people, but also that we need to figure this one out, because it is the foundation of all of this, besides wearing face covering and washing your hands, right? And keeping your distance, is that if you are sick, that you are not allowed to, right, expose others, which is so very important. And, the other piece is, it means you cannot take medication and then come to school, right? It has to be without medication. And I think, Lisa, the rule is 72 hours. So there's quite a long time that's identified. So we have work to do there, and we'll be doing more of that. This is a big one, seasonal allergies. Will I be excluded because I have a runny nose?
You should not be excluded if you have seasonal allergies. You should take medication that would limit the runny nose that you're experiencing, or rhinorrhea that you're experiencing. And this will be a challenging, I think this is the challenging space as we move into the school year, is some of it is how I've seen people who sneeze. When you see people sneeze and cough now, we all have a very different reaction to it. And a lot of times it is seasonal allergies. And it's, again, us as a group accepting, yes, trusting that, yes, just allergies. Although I've also heard people say it's allergies, and I know they've been sick otherwise. But I think that's, again, for us to really take individual responsibility, us educating parents around really not, making sure that they're assessing their kids appropriately before sending them to school. But you would not be excluded based on a runny nose. But again, I think that's a hard part as an employer. That's also navigating the employer space, is when someone presents as sick to work, that's always a tricky situation. So I think it'll be tough for some to navigate this space as we move into the year, knowing that that's absolutely, allergies have symptoms very similar to COVID-19.
Okay.
And then there's one thing that came up on the chat around tests. I just want to address that. We continue to work to expand testing availability. When we did have a call, we check our testing, the time that it takes on our own system to schedule testing. And now last week, where it was within a day or two, you were able to get a test. Now it's pushed out over a week. And that was what I was alluding to earlier. When we recommend any baseline testing requirements that are in place. And so what this group may not know, this month it becomes required by health officer law that skilled nursing facilities and residential care facilities for the elderly, their staff must be tested monthly. And so what's happened with that order going into place is the demand for testing, which was not as high 2 weeks ago. It was high, but it wasn't as high 2 weeks ago. That new surge of a group of people who are required to have testing has now backlogged our testing capacity. Also, San Quentin is backlogging the testing at San Quentin is backlogging the receipt as testing results. And so these are all challenges in our system where we're not in the business as usual. Your kid has a sore throat, or you have a sore throat, you go to your ER, they check your throat, you have strep, you don't have strep, and you're done. We are still in emergency use of these tests. This is not the ideal testing environment. We're still providing it's an emergency testing environment, and depending on health orders that may come in a different sector, it may impact the availability of testing, that was what I was alluding to earlier, where we know the requirement of baseline testing for teachers and staff would put a significant demand on our already limited resources, and we have to make decisions around resource allocation during an emergency. And that's one of our challenges. That's the thinking we're constantly weighing on a daily basis, is where do we invest our time, our energies, our resources to most efficiently reduce the spread of disease and reduce the risk of poor outcomes in our community. And it's a constant tightrope we walk.
Okay. All right. Sorry. Thank you. And I know we've hit our time. So this is staff and students who are sick are expected to stay home. So there's a question here about subs. What's that going to look like? And want you to know that we are, that's another thing that we're working on, and that would be people who potentially could be moving from school to school, and we're not yet there related to the guidelines. So we'll be working on that. What if a staff member develops symptom in the middle of the day? I think I addressed that. Does public health have a letter to families that can help put emphasis on the importance of keeping students home if sick?
We are developing that letter, and now we had a letter that went out to parents at the end of the school year. We'll be targeting it at the right time as parents are coming back online and preparing for the start of the school year. It'll be something we probably have to identify different strategies with social media, et cetera. Again, just for parents have a lot of opportunity and responsibility to help us, by minimizing the social activities of their kids outside what they deem as essential for their personal and emotional development and their educational needs. So starting with that, starting with making sure that they don't send sick kids to school, and that they report if they have any known close contact, because that's the other part. When people report to us they have a known close contact, that allows us to react and respond much more rapidly and prevent unnecessary cohort closures. So that's something that we'll continue to work on and learn how to keep doing it better, to keep this community informed and working to protect each other. And that's, we all can do tremendous amounts to protect each other.
Great. Okay, we're going to need to stop here. Lisa, I know that was a lot. Thank you very, very, very much. We really appreciate it. For those that want a little more information about these 7 items, 12 o'clock, there's another opportunity to get more specific about where the trainings are, etc. Lisa, we look forward to either having you or Dr. Willis with us next week, Thursday, same time, 9 o'clock, and we'll be looking at the next 8, I think, of the next 7 or 8 of the guidelines. So to all of you, thank you very much. It is very important that we continue to try to answer the questions that are coming up, and appreciate your participation very much. So thank you. Bye.